recently walked into a pharmacy store to buy some, few needs. A few minutes later, a young man looking very tired and frail, sweating all over, well, tired from probably walking for some distance to the store, or so I presumed. But he seemed, a frequent, visitor to that store. And of course, my suspicion was confirmed when, when I heard that the matron nurse asked him, "But you treated malaria only 2 weeks ago." Now, the young man could only muster a nod and added that he only had running nose and slight fever. And the nurse went ahead to administer some form of medication, but also advised him to return if he felt no improvement in his condition. But I also chipped, of course, in that he should also go for malaria test and take more fruits and fluid. So such visits and complaints at pharmacy stores in Nigeria are not uncommon in urban cities in different parts of the country. In fact, just my own survey, 6 out of every 10 persons you come across today in Nigeria complain of treating malaria or having treated malaria within 2 weeks of interval. And in the rural areas where you can only find chemists or patent shops, patients just walk in and ask for a particular brand of malaria drugs, while others simply administer the traditional herbs known as agbo or other sort of concoctions. So malaria is endemic in Nigeria. There's no doubt about that. Nowhere in this country is malaria free. It is a major or one of the major public health concerns, not just in Nigeria, but also in Africa, and one of the leading causes of avoidable deaths, unfortunately, especially in neonatal children under 5 years of age, and most especially pregnant mothers. A 2021 World Health Organization report shows that Nigeria bears the highest rate of malaria globally, accounting for nearly 27% of the global malaria burden. It is estimated that within this period, Nigeria recorded 68 million cases and 194,000 deaths due to the disease. Comparatively also, Nigeria currently tops the 5 severely malaria-impacted countries in Africa, although recent reports also show that global reports, yes, from global partners and world institutions like the WHO and of course Malaria Consortium indicate that significant progress is being made to attain global goal of eliminating the disease in Nigeria. There is considerable drop of incidence and death rate has also improved recently. But still, despite long-standing initiatives by governments, both federal and state and partners, malaria remains a major health challenge, overwhelming Nigeria's health systems. And of course, it consists of 60% of the country's outpatient visits and 30% of hospitalization among children under 5 years of age. And over the years, government and non-governmental organizations, as well as partner agencies, have come up with several intervention programs and strategies to end malaria in Nigeria. And they will include, of course, we all know the Rollback Malaria Program in the early 2000s, National Malaria Control Program, NMCP, of course, which dovetailed into the National Malaria Elimination Program, NMEP, the National Malaria Strategic Plan, in line with WHO recommendations, of course, to scale up response towards meeting the goal, the SDG goal 3.125. Former President Muhammadu Buhari inaugurated the Nigeria End Malaria Council, NEMC, in August 2022 to step up advocacy for funding, support, and coordination with the Nigeria Malaria Strategic Plan. But again, despite all of these, malaria has remained a leading health challenge in our country. So this brings us to the question, is there any end in sight to end war against malaria? On Late Edition this week, our attention is drawn to the activities of partner agencies like the Malaria Consortium to support Nigeria in getting malaria malaria-free certification. I am Claire Adelabu Abdulrazak, and I thank you once more for joining me. James Tade is the Chief Executive of Malaria Consortium. It's one of the world's leading non-profit organizations dedicated to the prevention and control, treatment of malaria and other communicable diseases. He leads a team of over 500 staff in over 12 African countries in Africa and Asia. He's also an honorary associate professor in the Faculty of Infectious Diseases at the London School of Hygiene and Tropical Medicine, where he teaches and supervises students and also conducts researches on malaria and other tropical diseases. He's also a fellow of the Uganda National Academy of Science. Mr. James Tade also holds a PhD in epidemiology, of course, an MPhil in epidemiology from the University of Cambridge, and he also has an MBCHP from Makerere University. My next guest is Dr. Godwin Inam. He is a public health expert and a medical parasitologist. Of course, he has MBBS, MPH, and PhD, all in the area of public health. Now, in 2009, he became the head of case management branch. Is the post he held until December 2017, when he was posted to head the epidemiology division of the Federal Ministry of Health, and also appointed as the chief consultant epidemiologist of Nigeria. Dr. Tade was redeployed back to the National Malaria Elimination Program as the national coordinator of that program. Again, he is currently serving as the national coordinator of the Nigeria Malaria Elimination Program. Gentlemen, let me warmly welcome both of you to Late Edition this week, and I want to thank you for obliging our request for this interview. But particularly, let me quickly congratulate Dr. Are you a doctor?
Yes,
MBBS. Yes. So, Dr. James Tade. That's the correct pronunciation.
Yes,
Tade.
Yes.
Let me congratulate you, on your new role. Of course, not just as a very strong end malaria advocate, but of course a soldier whose arms are just, advocacy and probably armed with data.
Yes.
I want to congratulate you on this new role. And again, you are not, I was going to say welcome to Nigeria, but my conversation with you shows that you are not new. Indeed, you are born, bred, buttered, and everything here in Nigeria. Yes, so you are a Nigerian.
Yes,
so good to have you on the show. And Dr. Tade, you are our own. Congratulations also on your new role.
Thank you.
Yeah, yes. So let me, you must have had your own personal experience with malaria.
Yes.
Can you share with us? Have you been bitten once, twice?
I'm one of the malaria survivors because, incidentally, I think when I was probably just in the first year of my life, just quite early, I had a fever. My parents, it was late at night, and my dad checked me before he went to bed and felt that I was very, very hot. And he remembered something from his days in secondary school, where they had said, if you have a fever, one of the things that you could be suffering is malaria. Now, because of growing up in Uganda, my parents, they had not had the experience of malaria in their lives. There's a part of Uganda, the southwest of Uganda, which is very, very cold. It's very high altitude, and so malaria is not common there. And he decided to rush me to the hospital, one of the clinics in Bodija. And the doctor said that if they tested for malaria and found that I had a lot of parasites. And the doctor said that if my dad had not brought me that night and had waited to bring me in the morning, that I would have likely not survived. So they gave me, I think at that time it was quinine or chloroquine. They injected me, and within a few days I was better. So I'm one of those survivors who was very lucky that not only could my parents recognize that I had a fever and take action, but I'm one of those who's very lucky that I had access to services, and that within those services, the health workers were able to detect and give me the right treatment.
Just before I bring in Dr. Tade into our conversation, also because you've been in this business of, trying to end malaria, especially on the African continent for a long time. I'm sure you must have some, apart from yours, you must have some other personal shocking experiences. Yes.
Yes, Claire. Very, very shocking experiences, and that's why I'm really a keen advocate. The devastation that malaria, imparts on families. In my clinical experience, I used to see on average, something like 50 children in every single day. And of each of those children, the number that would die, the majority of those were malaria. And I remember 2 examples where this mother came to the clinic, to the hospital, and she was carrying her sick child. And she sat in the line, patiently waiting for her turn. By the time we got to her, her child was dead in her arms. But as a health seeker, she sat there waiting for the health system to take care of her child. Another devastating experience I sort of remember vaguely was a mother who, brought a sick child to the health facility we treated, and she said, look, she can't stay. She has to rush back home. And we said, why? She says, because at home she has heard that her other children are also sick.
Down with malaria.
And what is probably likely is that she came with one child who has malaria, and the other 2 at home were probably sick of malaria. So we gave her her treatment, and she had to rush back home. And those stories keep reminding you of the devastation that this disease has, not only on the lives of families, but also on the economies. Because you can imagine that mother, she can't go to the farm, she can't look after her children, and imagine the economic impact it has on a family when for each child that you have, and that child is falling sick maybe once every month or once every 2 to 3 months, that is a cost that a family has to bear.
Lucky you for living to tell the story today, and of course, unfortunate for the mother, the pictures that you have painted. It's not as if those pictures are gone. I mean, I just painted a picture of what happened just recently, of the young man who just walked in. Dr. Tade, I'm sure you're familiar with such stories.
Absolutely. Yes, it's really a major problem, and just like Dr. James has said, one of the incidences I still remember clearly was from my primary 3 to 4. It was exam time and I felt sick. Unfortunately, I couldn't do the exam. I was only promoted based on my first term, second term performance. So I can imagine in a situation where you see so many numbers of children falling sick, affecting their performance, people in the market affecting their performance, because of course if you don't go to the market you won't sell. Workers in the office, if you go around the country and ask, why are they not coming? It's either they are in the hospital or they've taken their children to the hospital. Of course, you cannot tell them not to go. And also, like has been said, in the hospital, if you work in the hospital setting, some of the things, some of the diseases, especially children, is malaria. I've physically seen a child depreciating onto death And it's usually
Because
a
of
very
malaria?
harrowing experience, because when they go to when they develop severe malaria, you will not be able to, the manifestation changes
Which
from
one is
convulsion.
Which one is severe malaria? Because I know sometimes when you go for your test, they come and they tell you, oh, you have 3 titers or something like that. So what does that really mean in terms of treatment?
Well, when there are ways you grade it. You either grade it as uncomplicated malaria or severe. And when it comes to severe, the chances of survival or dying is 50-50. Because at that point, so many other complications may just arise at any point in time. So the child may just begin to convulse. The child may suddenly begin to have blood coming out of the ears and all the orifices. The child may just go into coma. If you pinch, you touch, the child does not know what is going on. And at that point, only sometimes intervention may be too late.
Just because of malaria?
Yes.
Just because of malaria?
And
Yes.
the dividing line is so thin. I was in Damboa in Borno State. We were doing a study when they brought in a child. In the process of taking history, the child just went to coma. That is, just lost consciousness completely. And we admitted, unfortunately, we lost him. This is a boy that came into the clinic holding kosei akara in his hand.
Yes, bean ball.
Yes, bean ball in his hand. And we were just clacking, asking questions, asking the mother. Then suddenly, he lost consciousness. Unfortunately, he died. So the line dividing severe and uncomplicated is so thin. And that is why whenever we are talking, we say, treat malaria promptly, because we will not be able to predict the next complication.
And it's worse when it comes with, sometimes you go to the hospitals and they tell you, oh, you have malaria and typhoid combined. Now that's a very worst case.
Yes. So these are just the thing. Malaria, you underlook it, but is a disease that comes with is hidden weapons, which you don't pick immediately until the child tilts to the other end.
I'll come back to you to talk to us about altitude. I just said common malaria. I was expecting you to react to that. But that is the altitude
Yes.
of Nigerians towards,
Yes.
the
Yes.
disease.
Yeah.
We treat it with a lot of complacency.
Yes.
It's common, it's casual, and then, we wave it off when we feel it. But what part of the body organs, does it really affect? Because I got scared when you talked about the boy with the kose, suddenly slipping into coma.
Yes, malaria literally affects every part of the body. It's one of the diseases that affects every part of the body, unfortunately, because the parasite goes within red blood cells, and as you know, red blood cells are circulated around every part of the body. So wherever there are red blood cells, once one is infected with the malaria parasite, they will be present. Now, what tends to happen, as I think Dr. Ntadom is describing, is that the parasite changes the shape of the red blood cell. And because of that, the red blood cell is not able to carry oxygen sufficiently. And two, because of the change in shape of the red blood cell, when the red blood cells are moving in the bloodstream, they stick to each other. And if that process continues, that stickiness means that as the red blood cells stick and compact each other, they will block blood vessels. So when a child loses coma, it's because of the fact, or even an adult.
Is that a form of blood clotting or something?
Yes.
Okay.
It's called blood agglutination.
Agglutination.
But what happens is that as the blood is clotting, any part it blocks means that the part of the body after that blockage is not receiving oxygen. And that's what happens to the brain, where the child loses consciousness, or any other organ, for example the kidneys, where that circulation is not happening properly. The third thing is that not only does it change the shape of the blood vessels, it also makes the blood vessels erupt. So the blood vessels burst open. And that is how the malaria parasite then propagates itself. So it gets in, changes shape, and makes the blood vessel burst. And then out of that blood vessel comes more parasites. Now, by that blood vessel bursting, by that red blood cell bursting, imagine you're losing red blood cells that should be carrying oxygen. And so the capacity of one's blood continues to reduce and reduce. In addition,
and that is sorry, and that is when they tell you you don't have enough blood.
Yes,
that's part.
Yes,
okay,
that's part of it. And then there are chemicals that get released because of the parasite being in the red blood cell, the red blood cells erupting. There are all kinds of chemicals that get released, and those chemicals cause fever. Those chemicals cause,
At what stage does this happen? Because, somebody could just wake up and say, oh, I'm not feeling well, and then wait. At what stage should, in fact, you said, please, at what stage does this happen?
It's very, very quickly. Actually, when a parasite gets into the human body, within something about, within a week to 2 weeks, that parasite has passed through the liver, is in the red blood cells, and is multiplying in the red blood cells. And what happens is that depending on one's age and the level of immunity, one is able to sort of control the number of parasites. But why malaria is common in children under 5 and pregnant women is that their immune system is not sufficiently developed. But even adults, all right, I think one of the points we have to be clear is that even adults, you can still fall sick. And sometimes there are parameters that change. For example, when people travel, travel itself can actually create the weakness in the immune system that can actually make you succumb to malaria. So there are a variety of factors. But what happens is that within 2 weeks you already have red blood cells that are infected, and those red blood cells are starting to multiply other parasites.
And that's why you need to attack it immediately you have symptoms.
Yes.
So that you stop it from progressing.
Yes.
Dr. James Tade and Dr. Godwin Inam, I'm sure you'll be shocked that we have done half of our scheduled time. So we'll just take a short break. When we come back, we'll now look at the activities of Malaria Consortium and, of course, initiatives to support and help Nigeria attain end malaria program. Don't go away.
You can't fight piracy, you can't fight a war.
Therefore, you don't claim your rights.
The challenge I see is in the fiscal.
Do we have to wait until we have a problem?
See, the problem with those who speak on behalf of themselves and the country is that they should have facts. I'm speaking now as Minister for Transport.
For you to become economically independent, you must have to curtail the level of importation of other people's products and services.
How rich you are, you can't bring certain vehicle into the country.
There's no competitiveness within the state.
I am Claire Adelabu Abdulrazak. Thanks for joining me. Welcome back. You're watching Late Edition this week, and we are focusing on activities of development partners helping Nigeria to attain the malaria elimination, of course, by the year 2030. It's one of the Sustainable Development Goals, specifically Goal 3. And I have the CEO of Malaria Consortium, Dr. James Tade, and our national coordinator of National Malaria Elimination Program, Dr. Godwin Inam. Gentlemen, thank you very much once again. So let's quickly get to the crux of our conversation, and that's what Malaria Consortium is doing. And just talk to us about your new role in Nigeria.
Thank you very much, Claire. I am the Chief Executive of Malaria Consortium. It's a global non-governmental organization. We've been in Nigeria since 2008, and we've been working very, very closely with the National Malaria Elimination Program to implement its strategy. Some of the things we've done in Nigeria, with support from development partners like the FCDO of the UK government, the President's Malaria Initiative of the US government, Bill and Melinda Gates Foundation, several other partners, has been to really support the program in how it deploys proven interventions in a manner that tries to achieve the highest benefits to Nigerians. An example is the seasonal malaria prevention program that we worked very closely with the National Malaria Elimination Program. We started these activities with a very small project in Katsina State. I think it was around 2014. And there we covered about, I think, 150 to 200,000 children with seasonal malaria prevention. From that point to now, with the support of the Nigerian government, we're managing to reach more than 20 million Nigerian children. I think it's probably close to about 23 million. So we're now reaching, in less than 20 years, we're reaching close to 23 million children with seasonal malaria prevention in the locations that we're working in. We've also worked very closely with the program on insecticide-treated nets, making sure that the model that is used to distribute nets is one that is based on evidence and one that is tailored to the context of Nigeria. And we have worked very closely.
I would like you to really expatiate on that because some years back in this country, I think I was in one of the southeastern states and covering rural areas, and it was going to become a trend, for people to sleep, under treated mosquito net, long-lasting treated mosquito net, and then suddenly it's just.
Yes, I think it's multifactorial, but I'm sure Dr.
Yes,
Interdam will have some. I think
yes.
it's multifactorial. I would say that we have seen certainly a decline in the burden of malaria. So the experiences that people have, the lived experiences that people have of malaria is probably declined to the extent that we don't see malaria as an immediate threat any longer in some locations. And so I think what that then means is that you may become less consistent in the use of proven interventions. I would say that's probably one. I think the other is, I think over time, these diseases, I think we become normalized to them. And I think, as you pointed out, the common malaria is something that I think we also have to consistently keep reminding people that even though you don't live the experience, the parasite, the vector are still around. And what we must remember is that even if I don't get malaria, I should use a net to prevent my neighbor from getting malaria. Or I should use a net to prevent my child from getting malaria. That link is missed. The fact that by using a net myself, by treating myself effectively, having tested, means that I protect my neighbor from the disease. That linkage gets missed. So because I don't experience it, I would say, okay, I'm not using a net. But what I forget is that I am the route of transmission. Because if I have the parasite, the mosquito will pick the parasite from me and give it to the next person. And that next person might be a child under 5 who doesn't have immunity that I have. So I think there's several factors that have kicked in. And one of them, I think, is the fact that because of the success that has been achieved, I think there's some complacency in the use consistently of these tools.
Dr. Tade, the malaria prevention, yes. Can you speak to us about progress? He has given us some statistics, but so far, what is the behavior of patients? What is the behavior of adults? To having their children, get the treatment.
Yeah, thank you very much for that question. Let me start from the earlier issue you raised about malaria being called common. In the past, it was actually called simple malaria, making it even more until after some time, there's nothing simple about a disease that can kill almost 1 million. And that was why the name was removed as simple malaria to uncomplicated malaria. Now, coming to chemo prevention, malaria chemo prevention, that is the SMC seasonal. First, because in the north, when you look at the north, you don't really have malaria problems as such when it is not raining. Because one of the common reservoir for the vectors are rainfalls and stagnant water. So that's how it was planned, so that we normally target the periods where malaria cases usually occur. That's when the activity. And I must tell you, since we started this program, we started with 9 states many years ago, but we've expanded it to cover 22 states now. I must tell you, it's one intervention that is well embraced by the communities. And if you go around the entire north, we started with the Sahelian region to the Savannah, but we've even brought it down to include almost all the states in the northern part of the country. So the idea is when you give it to children, it clears the parasite to an extent. And of course, if it clears almost all the parasite and the child cannot have the infection, it is unlikely that that child will die as a result of malaria. So it is the acceptance across the country has been very wonderful. And it is, we as a program also has tried as much as possible with support of partners like Malaria Consortium in logistics and even in providing the commodities. We've been able to deliver. We just completed this year zone in all the states. So it's an intervention that, like I said, started with 9 states, has increased to 22 states, and we are still moving. And also, apart from that, we are also thinking of ways to make it better than it is presently.
Dr. James, you talk about collaboration with other partners, in this fight and what you have been able to do. And we know that to prevent malaria, it's not just a tax for those in the health sector alone. It's multi-sectoral. So I'm wondering, because you need a lot of orientation, you need a lot of advocacies. How much have you engaged the media in this area?
Thank you very much. The media and I think any communication channel are key. We've done a lot, I think, in the past, maybe not as much, and what I would like to see is really more engagement with the media and all the other channels as well. I would say information and having the right information consistently over time is vital. The media, whether it's visual media or audio media or even social media, I think what we've seen is that getting the right information to populations is critical. And I also think what the COVID pandemic has taught all of us is that the media is also a channel through which misinformation can take place. And what I've realized with practitioners like ourselves is that we are not conversant and good in reacting to misinformation. It's probably one of our weaknesses. We try to give correct information, but what we have seen, I think, with social media is that often there will be information that is not fairly accurate, and we don't know how to react to that. So what I would like to see in the future is, organizations like ourselves, I hope programs working very closely with getting the right information and also addressing misinformation in a way that communities trust what we say. It's vital, because without that trust in communities, 50% of our work can't be done.
Yes, is that likely to be something that the National Malaria Elimination, program would now begin to mainstream? Because we talk about new approaches. I know there's been call for innovative, technological approach, and a lot of our youths are trying to come up with, such innovative, ICT-driven,
Yes.
approach to pass information, to obtain data, and all that. But again, you also need, mainstream media to be able to carry this information and convey. For instance, you hear a lot of talks about, I talked about traditional, medicine, herbs. A lot of people believe in the use of agbo. If you go to the rural areas today, I can tell you the majority of the population there use and indeed rely on, these concoctions to treat malaria.
Yes.
A lot of them also watch the television.
Yes.
And listen to the radio. Doctor, please, anyone can take that.
Well, thank you for that also. You see, the medicine that has been adopted, which is the artemisinin-based combination treatment, the artemisinin is a herb developed to a point where it is now formulated into tablets.
Yes.
So, in malaria control, you can't rule out the place of herbal treatments. I'm sure many institutions like INAPRID and other organizations, they are working on this. And of course, for you to bring out any medicine for population use, like focusing on like I put it as programmatic use, you have to analyze several things, not only the benefits. Are there some side effects that may cause some other diseases? You may, in the process of trying to treat malaria, you are damaging your kidney. So all those things have to be done completely until it will be certified. And when we talk about certification, Nigeria subscribes to WHO. It has to go through those processes, and it will be recommended. Artemisia was not originally a Nigerian product. It was a Chinese product. But after going through all those processes, the Chinese have been using it for ages.
Yes.
As local treatment. It started coming out around 1973, where they said, this. And the adoption was 2002. And so many countries have taken into it now. So in Nigeria also, we made an attempt to grow the same Artemisia. But even if we are not talking about Artemisia, we still have other products that are being promoted, they are working on presently. I'm aware.
Dr. Tadam knows all this. Some of us broadcasters don't have, these details.
Yes.
So is there a way in which, I don't know, I'm thinking of a kind of specialized training for broadcasters, to be able to also be part of this vanguard?
Yes, certainly. I think that's something that as an organization we'll be keen to support, because we've all got to be champions, we've all got to be vanguards. And what I would like to stress is that the journey ahead is probably more complicated than where we have been, because the threats that we're facing with drug resistance, insecticide resistance, the lack of appropriate funding are challenges that require us to be astute with information and to get the message to everybody. The other thing we must keep in mind is that as the disease declines in terms of severity and impact, the complacency will kick in. And not only that, the chances are resources start getting moved to other burdens. And it requires the media, it requires the advocates to be able to continue stressing that we are aiming for elimination. It's not just control. And the journey to elimination means that it's not complete until the last case is detected and treated.
That brings me to my next question, because I must be fast forwarding now. At what stage, you talked about control stage, there's the pre-elimination stage, and of course there's the elimination stage where you don't have traces, and that's the stage where you are given the certification.
Yes.
So for Nigeria now, I don't know who I should be asking. Okay, let me take it to you. At what stage is Nigeria? I know we are not, I don't know if we are even at the pre-elimination stage yet.
Okay, let me just explain. Like, there are some criteria that has been set. As long as you have cases, that is 5 per 1,000. That is when you see people presenting with fever and all those things. And out of them, 5 are positive. You are still under control. Nigeria now, we are in 23. So technically, we are still far from. In fact, the prevalence is 23%. Yes. Now, what I'm talking about is you now move to 1,000. People that are doing pre-elimination now are in 1 per 1,000. That is, out of 1,000 cases you test, only 1 becomes positive. Among
children or adults?
Everybody.
Everybody?
Yes. That is cases, yes, generally. Okay. 1 is positive. Then it will get to a point that you may not even get anyone. That's when you now begin to look whether it is an indigenous transmission or somebody, because it is possible. If a Nigerian goes to a place like, let's say, Botswana or any other country, Lesotho, that have achieved, that are close to. So they want to know your parasite. Are you bringing it from Nigeria or is an indigenous one, the local one? So at that point, if you are able to monitor for 4 years without any case, you have achieved elimination.
So where are we now?
Because we are still in control, aspiring to enter
and that is where Malaria Consortium is urgently needed.
We have been working. I must tell you, we have received a lot of support from Malaria Consortium. Not only in the, Dr. James was emphasizing seasonal malaria prevention, they do beyond that.
Yes, he also talked about the use of long-lasting insecticide nets, yes. And I'm sure you're also going to talk about the indoor residual spraying.
Even programmatic support.
Okay.
Severally, they've assisted us with officers, technical officers that are within the program that are supporting us in technical areas, which is a lot of benefit to us.
Is it adding value? Is it getting us nearer to goal 3? Goal 3.
Absolutely. One thing we've been able to achieve in a way is there's no way you put it, but we have actually achieved some reduction in mortality. If you go to the field and obtain practical experience, you know that children are no longer dying as they used to be as a result of malaria. And like we said, the seasonal malaria prevention has contributed significantly to reduction in mortality. Because if you don't have the uncomplicated malaria, you cannot just have the severe. Because it's the journey, you start with uncomplicated, you move to the severe. But we've been able to, with the support of our partners and the federal government of Nigeria also, we've been able to bring down the number of people who go to the facility as a result of malaria.
Dr. James, how effective, have these vaccines, especially the seasonal chemoprevention, therapy, how effective has it been? And also talks about, malaria vaccine. And people keep wondering if we're able to come up with COVID-19 vaccine so fast. What is delaying a malaria vaccine, that can keep Nigeria, patients safe from infection in the first place?
So, in terms of seasonal malaria prevention, which is a drug that is given during the peak season or during the time when transmission is highest, I think, remember, transmission is there throughout the year. Really, what we've seen, and I think the evidence has shown even in Nigeria, is that seasonal malaria prevention prevents up to 70% of malaria cases from occurring during that period, which is a huge benefit to the population. I would now like to switch to malaria vaccines, because I think this is one area that we need to work very, very closely with the media, because there's a lot of information that also has to be shared. I think the first thing to remember is that COVID is a virus. And so vaccination against viruses, and I will say this with humility, is easier. Malaria is a parasite that has multiple stages in the human body. Developing vaccines against parasites of that nature is complex business. Which is why for COVID, we could create vaccines that were highly effective within a 12-month period and have them approved. The malaria vaccine that was recently approved, I think it was in 2022, because there are now 2 malaria vaccines that have been approved, took 30 years.
RTSS.
So there's RTSS and R21. That the first vaccine that they approved took 30 years to develop, because every single step of the way was they needed to do research, they needed to improve it. And what we've seen is that because the first vaccine took so long but paved the way, the next vaccine that has been approved took a shorter period of time, because they were able to sort of base it on previous evidence. The vaccine does not work alone. It requires the use of nets. It requires the fact that if one has a fever, one still needs to go for testing and treatment. So the vaccine works alongside the other interventions. We don't yet have that magic vaccine that's going to work alone and is going to dramatically stop disease and transmission. That type of vaccine is called a transmission blocking vaccine and still has a long way to go before we have it developed.
What happens if a child, I'm sorry to interject, if at the expiration of the seasonal chemo prevention drug administration, at the end of the doses, what happens? Does the child get additional one, or I don't know, how long does the drug last?
Okay, thank you very much. The administration of seasonal malaria chemo prevention does not disrupt the routine facility work.
Oh, okay.
We still provide anti-malaria medicines to all the facilities. Even when the SMC is going on, it is possible for a child to have malaria. They are treated accordingly in the facility.
Okay.
So it's not just a one-off thing.
Yes.
It's just an additional intervention to the routine diagnosis and treatment.
Okay. So Dr. James, tell us, you are in charge now, and you are in Nigeria. You know what the challenges are. Basically, I say this because, from the research, all the countries of the world that have attained malaria-free certification have also applied, all the approaches and, strategies towards malaria elimination, from indoor residual spraying to the use of insecticides, to adoption of technology. Nigeria also is doing the same, but it's not achieving the same result. What are your new strategies?
Thank you very much. I think there are a couple of new strategies, and I think the key for me is that there's new leadership in the Ministry of Health that is really committed to a vision of improved healthcare and a vision of primary healthcare in Nigeria. That is key, because a elimination program is stronger if a health system is resilient. And so the future requires a resilient health system in Nigeria that provides quality basic services to its population. Without that, malaria elimination remains distant. So I think looking forwards is that the government is committed to that and is looking to deliver it. And I think we commend the Nigerian government and the Ministry of Health for that vision. And really, we look forward to the realization of that vision. The second thing is the use of data. There's an adage that if you can't count, you can't measure. Sorry, if you can't measure, you can't manage. We need to be able to count and measure malaria wherever it is happening in Nigeria. without doing that, some of these interventions will not achieve the benefits, be they vaccine or be they seasonal malaria chemoprevention. And I think the National Malaria Elimination Program, as well as the Department of Public Health, are committed to really seeing that the accuracy, reliability of data that comes from routine services is strengthened and is utilized. That is something that's critical for the future. And then we look forward to the introduction of next generation insecticides that are in nets, which make the nets more effective, which make indoor residual spraying more effective, and the rollout of the malaria vaccines. So I think these tools are coming on board, but they need to be deployed appropriately. They need to be monitored to see how they are performing, and that data has to be used for decision making. Thank you.
Dr. James, I'd just like in 60 seconds for Dr. Ntadom. Now you're in charge of the elimination program. And again, from research, other elimination programs in other countries, especially the End Malaria Council, which the former president inaugurated, also have, adjunct, partners, moving into the rural areas and also passing information and coming up with initiatives. What are your strategies? If you can, in 60 seconds, I'll be glad.
Well, you've mentioned the End Malaria Council. We are counting on it. The process is ongoing. And also we are trying in a way to stratify the country and prioritize interventions to deploy. That's one thing we want to, and Dr. James has talked about data collection, have the accurate data that will enable us to plan and also know how to move forward. Because it's when you are able to pinpoint where these burdens are, then you know what to do. So those are some of the things we are working on
at the moment.
Yeah.
Wow, I wish there's so much to talk about malaria. Indeed, it's a very complex disease, and it requires more than 1 hour to really have an extensive and valuable conversation. But Dr. James Tade, I must appreciate you finding time to come share of course your experience and your new strategies, how you intend to lead this new team to success and help us out of the woods of malaria problems. Thank you very much, Dr. James Tade, for coming to Late Edition this week.
Thank you very much, Claire.
Dr. Godwin Inam, I know I will have you again. I also look forward to having Dr. James also on Late Edition. Thank you. And we wish both of you all the best in your new roles.
Thank you so much.
All right, that's it for us on Late Edition this week. We thank you for watching. From me and the Late Edition crew. Goodbye.